Good morning, all, uh, and Department of Urology, Ramachandra Medical College, and Savita Medical College. We welcome you all for this the next session of our online program. We conduct this on a monthly basis, and this today we will have an online session on CA prostate. CA prostate is such a huge topic. We covered it last time. Also, we tried to cover as much of basics of CA prostate as possible in the last session that we had on 3rd of August. Not many of you who had not many of you who missed out the earlier session are present today. We have had an unprecedented number of registrations, around 148 registrations, which have happened till now, which is something which is very encouraging for us. Let us see how many of you uh, actually participate in the program. The whole idea of this particular session is to give you some sort of a complete or a holistic approach towards management of CF prostate. Because as I told you earlier, CF prostate is one of the very, very vast topic. If you start reading Campbell's CF prostate, you will never know where you started. By the time you finish reading it, what you have read in the past or what you read in the beginning, you will completely forgotten. So it is always it's such a confusing topic. Arriving at some sort of a consensus is extremely difficult for us. So I will try to put everything very simple today as much as I can. And last week we discussed about the epidemiology and the role of PSA screening and this and the basics of CA prostate. Today probably we'll discuss various scenarios. We'll discuss localized CA prostate management, locally advanced CA prostate management, and the metastatic CA prostate, oligostatic, non-oligometastatic, how each one of these differ, and and finally we'll run through some landmark trials which are there for screening, for chemo prevention, for localized CA, and for metastatic locally advanced and all. So the next couple of hours, I think between 10 and 12, we will try to discuss as much of the management issues and the landmark trials as much as possible. We'll try to discuss. At any point of time in between, you can always interrupt me, get your doubts clarified. I think Surya and Dr. Aravind will keep a watch on the the uh, the 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 chat box also. Anybody has any doubts in between, you can always interrupt, and we can get those doubts cleared then and there, because it's extremely difficult for us to get all the doubts cleared in one go at the end of the session. So in between, if you want, you can always interrupt and get it all cleared. Okay. So Rajan, I think you are presenting today.
Yes, sir. Yes, sir.
You will start presenting, and let us see how we are able to take it further for discussion. Let us see. Okay.
Okay,
Fine.
sir.
Go ahead, Rajan. Yeah.
Yes, sir.
Urge 4 means the fourth one, is it?
Fourth session, sir.
Okay.
Good morning, sir.
Yeah.
Yes. A 69-year-old male patient who is a retired industrial worker who came with a chief complaint of poor flow of urine for the past 1 year and increased frequency of the micturition for the past 6 months. History of present illness, patient developed poor flow of urine with staining to white for the past 1 year. He also complains of history of hesitancy, history of incomplete emptying. There is no history of intermittency, and there is an history of post-vital dribbling on and off. Patient also gives complaint of increased frequency of micturition for the past 6 months with daytime frequency of 10 times and nighttime frequency of 6 to 7 times, with each wide of about 100 ml. There's an history of dysuria present, no history of any instrumentation, catheterization, or urethral discharge, no history of hematuria or passage of tissue bit. There is no history of fever, loin pain, or lithuria, no history of loss of weight and appetite, no history of bone pain, jaundice, or chronic cough, and patient has an IPSS score of 20.
Okay.
Past medical history, patient is a known diabetic and systemic hypertensive on regular medication. There is no past surgical history. Personal history, patient is an occasional alcoholic for the past 30 years, is quit for the past 2 years. Patient takes mixed diet with normal sleep and appetite. Family history, there is no relevant significant family history. History-wise, that's all.
Okay. So at the end of your history, can you summarize only the positives alone? Go back to the first slide and summarize only the positives in one line.
It's a 69-year-old male with voiding LUTS for the past 1 year and with storage LUTS for the past 6 months, sir.
Okay. What do you think this patient has got now?
So
He's
patient
got a mixed LUTs according to you.
Yes, sir.
And nocturia 6 to 7 times.
Yes, sir. So patient is having a bladder outlet obstruction, sir.
Okay.
Maybe secondary to BPH with IVP. Other differential diagnosis would be CA prostate, sir, considering the age of the patient, and patient was having predominant storage and wide inlets. And the other diagnosis can be large vesicle calculus and stricture urethra, but patient was not having any intermittency if it is a large vesicle calculus. And stricture urethra, patient is not having any previous history of instrumentation or urethral discharge, but still I couldn't rule out these two. In general examination, patient is conscious oriented afebrile, vitals are within normal limit, no cyanosis, clubbing, ictus or generalized imperinopathy, and ECG score of 1. The local examination, patient there is no phimosis, meatus adequate, glands and peen is normal, bilateral test is normal. Digital rectal examination, anal tone is normal, patient is having grade 4 hard prostate with irregular surface which is non-tender, median sulcus is obliterated, rectal mucosa free, perineal sensation is normal with normal BCR, and seminal vesicle could not be palpated separately.
Palpable.
Not palpable, sir.
Okay. Normal seminal vesicle, not palpable. Okay,
Yes.
if it's palpable, that means it is enlarged.
Yes.
And lateral sulcus, you'll have to define whether it is present or not present, obliterated, or whatever.
Yes.
Okay.
Yes, sir.
Fine. Go ahead. Okay. So now you tell me what are the differential diagnoses? You said clear prostate is one differential diagnosis.
Yes, sir.
What are the other differential diagnoses for a hard irregular prostate? Hard irregular prostate is CA prostate understood otherwise.
Yes,
No questions about that.
Yes. Chronic
Then
prostatitis can also have hard irregular prostate. Granulomatous prostatitis can also have irregular prostate, hard irregular prostate.
Okay.
Then prostatic infarcts.
So what you mentioned in the differential diagnosis, the large vesicle calculus you said, can
Yes.
that actually mimic
Yes, sir.
a hard irregular prostate?
Yes, sir.
Yes, that also should be.
Yes.
CA bladder base infiltration into the prostate also will mimic a hard irregular prostate.
Yes, sir.
All this you should keep in mind.
Yes, sir.
When you say CA prostate, all these are the other differential possibilities that you have to keep in mind.
Yes,
Rule out one by one, one by one, one by one. CA prostate unlikely because this patient never had a hematuria.
Yes, sir.
Okay. Vesicle calculus unlikely because this patient did not have intermittent, but still you should keep that as one of the distinct possibilities.
Yes.
If the examiner is asking you anything else, you should think of all this. Simple BPH, which is nodular, that can also produce a variegated consistency in chronic prostate. All this can also produce all this can also produce a similar finding in DRE. Okay, so when you say the hard prostate, all these things should run in your mind.
Yes,
and you should not think it's a very standard question that is asked in the exam. What are the differential diagnoses for a hard irregular prostate? Then you should say all these things. Okay, fine. What next? You've examined the patient.
So, as an extension, I would like to do an ultrasound KEB, also uroflowmetry with PVR, sir.
Okay, good.
So ultrasound, bilateral kidneys are normal in size and shape, sir. Corticomedullary differentiation is maintained. There is no pelvic system dilatation on both sides, sir.
Okay.
Bladder appears partially distended. Wall thickness appears normal. There is no intraluminal calculi or debris, sir.
Okay.
Prostate appears heterogeneous and grossly enlarged with a volume of approximately 176 cc, sir.
Okay.
In uroflowmetry, patient was having hesitancy with the Qmax of 10.4 with PVR of 26 ml, sir, and the average flow of 6.1. Corrected Qmax will be around 7, sir.
Okay. Fine.
So,
what do you think this patient has got now?
The patient was having a heterogeneous prostate, sir, with the poor flow. So I would like to confirm my diagnosis. I would like to do serum PSA, sir.
By looking at this flow, uroflow, what do you think is a possibility here? You said corrected Qmax of 7, you said.
Yes,
is there any other striking feature that you can see here? Which almost...
Hesitancy is there, sir.
Hesitancy is there. And why do you think it is a BOO and not a structure flow?
So in BOO, there will be...
You had structure also as one of the differential diagnoses, no?
Yes, sir. So patient is having long wagging tail, sir. It is not a typical box pattern of stricture, sir. Also
before that, will there be a hesitancy in structure?
In structure, there won't be any hesitancy, sir.
Okay, fine. Okay, what is the PVR here?
PVR 26 ml, sir.
Okay, fine, fair enough. Okay. The crescendo, decrescendo, and hesitancy point towards the BOO. If there is a box-shaped pattern, no hesitancy, emptying the bladder to completion, all this point towards the
stricture.
Go ahead. Okay, good.
So I proceeded with doing a serum PSA for this patient, sir, and routine along with the.
Okay.
Serum PSA was 3,182, sir. Serum PSA was 3,182. Hemoglobin was 9.2, sir. Serum calcium was 9.4 and LFT was within normal limits, sir. Also, urine routine showed glucose 3 plus and protein 2 plus. A patient known diabetic with RBC 23, urine culture sensitivity, no growth, sir.
Okay.
So, we proceeded with the trust biopsy, sir.
How do you interpret all these findings here?
So, serum PSA grossly elevated, sir, with heterogeneous prostate. Most likely to be a metastatic CA prostate, sir.
Okay, serum PSA is high. Okay, very
Yes.
grossly. Other than that, this patient had nocturia 6 to 7 times. No,
Yes,
we
sir.
thought it was because of BOO.
Yes, sir.
But in addition to that, you have an interesting
Glucose 3
finding
plus.
here. Glucose 3 plus that can also produce nocturia in a similar fashion.
Yes, sir.
Uncontrolled sugar may be the reason for his bothersome LUTS,
Yes, sir.
not necessarily the CA prostate. Okay,
Yes, sir.
that again you'll have to remember.
Yes, sir.
Okay, go ahead. You say heteroechogenous mass. Okay, heteroechoic mass. Not a prostate is only 18 cc here,
Yes.
but you are seeing something else beyond the prostate.
Yes, sir.
Okay, you are seeing some sort of nodal mass. Okay, which was probably misinterpreted in the ultrasound abdomen. Okay,
Yes, sir.
fine. That
Yes.
is the information you have.
Yes.
What next you want to do?
So I would like to do a biopsy for this patient, a trust-guided biopsy.
Okay, fine.
So,
You can do see there are two things. One, you can ask for a transrectal ultrasound and a transrectal ultrasound guided biopsy.
yes, sir.
Irrespective of the findings that you get in trust, you will need a biopsy because the PSA is grossly elevated
Yes,
and there is a clinical suspicion of CA prostate.
Yes, sir.
This is one entity. Okay, this is one way. The other group, which will say that trust is not required, will go for multiparametric MRI straight away,
Yes,
and we will do an MRI guided targeted biopsy of the prostate gland.
yes,
Okay, there's another group which will believe in that concept.
yes, sir.
These days, with MRI being rampantly being used right and left in every center, the number of patients who end up doing an MRI, getting an MRI done, MP-MRI done is much higher. So, what is your rationale of which one to go for? Will you go for a transrectal ultrasound and a transrectal ultrasound biopsy, like what you mentioned now? Or would you like to go for an MP-MRI if you work in a center which has got all the facilities available?
So for this patient with the grossly elevated PSA, I would like to go with trust-guided biopsy, sir.
Doesn't matter,
Okay.
nothing happens. I'm not a fussy person.
Okay, why?
So trust,
Hmm?
so
Why?
MRI we will do when the patient is not willing to undergo biopsy.
When will you do MRI? When will you do trust? That clarity you should have. Okay.
Yes.
Which is better of the two? We'll come to that little later when we talk about the various trials, which talk about MPMRI and transrectal ultrasound. But that clarity you should have when you ask for a trust. Which will you ask for? You said you'll ask for a trust. No? Why not MRI straight away? What is preventing you from asking for MRI here? No, I'm just asking. You can always rational it out. Okay.
So if suppose we are planning for, suppose we are thinking the patient is having low grade tumor and we are planning for radical prostatectomy, that in that scenario, MP-MRI will be useful, sir. But this patient already PSA was grossly elevated around 3000 and we are suspecting either it has metastatic CA
Okay. This is one scenario. Any other scenario where you will ask for MRI ahead of your transrectal ultrasound?
If patient is not willing for a trust-guided biopsy, sir, that time we can do MP-MRI therapy.
Okay. So what is your interpretation of MP-MRI?
So if PIRATS is 4 or 5, around 97% chance that it will be CA, sir, but 3% chance it can still be negative, sir, CA prostate, clinically significant CA
What
prostate.
you should actually say, like what you say is not wrong, but what you should say is, we do a PIRATS scoring with MP-MRI with an intention to categorize whether it will fall on the benign side or the malignant side, isn't it?
Yes, sir.
So that is your whole idea. If you have a PIRATS of 3, it is equivocal neither this side or that side. Leave that. 1 and 2 on one side and 4 and 5 on other side. If you have 4 and 5 reported, there is a 97% chance that there will be an underlying malignancy. Whereas if you have 1 or 2 reported, if you have PIRATS 1 or 2 reported, that doesn't mean that 97% of them will be benign. It is not like that. 20% there is a possibility that there can be some underlying malignancy as well, even with the score of PIRATS score of 1 and 2. Okay, so that is something which you'll have to remember. So pyrites is very helpful with a high, with the MPMR is very helpful with a higher pyrite score, and it is not so helpful in low pyrite score. Okay, to make a diagnosis or to rule out a diagnosis of CA prostate here. That distinction you should be able to understand and make. Okay, fine. Go ahead. What next you want to do? Done a transrectal ultrasound. What next?
Guided biopsy also done, sir. Biopsy reports.
Yeah.
Sir,
What is the biopsy report? I can't see that it's very small. Infiltrating adenocarcinoma of
infiltrating
prostate.
adenocarcinoma, Gleason score 4+4, sir, with the grade group 4, sir.
So generally, when you have such a biopsy being, the report is given to you, what are all the points that you will look for in any biopsy for that matter?
So first Gleason score I will see, sir, and grade group I will see, sir.
No, first you will see whether it is adenocarcinoma or non-adenocarcinoma.
Yes, sir.
So if squamous cell carcinoma, does the Gleason grade matter at all?
No, sir.
No, if it is a transitional cell carcinoma,
No, sir.
direct neuroendocrine variety,
Yes, sir.
signet cell carcinomas, Gleason's grade will not have a role to play there.
Yes, sir.
It's only for first whether it is adenocarcinoma or non-adenocarcinoma
Yes, sir.
variety. So that distinction you should be able to make first. Then once you make a diagnosis of adenocarcinoma there, then you look for Gleason's grade in that.
Yes, sir. The number of core positivity and percentage of core positivity, sir.
Number of core and the clinical stage also you should
Yes, sir.
remember. Okay,
Yes.
clinical stage also you should. Okay.
Yes, sir.
It's very important. Here, what is the clinical stage here? You did a DRE.
Yes, sir.
You have a serum PSA here.
Yes, sir.
You have a biopsy report of 4+4 here.
Yes, sir.
Okay. The next thing is last time I was mentioning about the risk stratification.
Yes, sir.
The moment you get such a biopsy report where you have 4+4 and a grade group of 4 and infiltrating adenocarcinoma, what percentage of cores are positive? Does that really matter here at all?
Yes. No, sir. This patient doesn't matter, sir.
Immediately you should think of this D-amico risk stratification, tabular column that we discussed last week. I'm sure most of you were not present here last time when we discussed the D. I'll be talking about the D-amico again today. Okay, that time I will brief you again. So that time you will know what exactly we are talking about. Okay. So this patient has got a PSA of 3000 plus. Irrespective of what the Gleason's grade is, what the course positivity is, this patient comes under a high risk.
Yes,
high risk to very high risk.
Yes,
I asked you one question. What is the clinical staging? How do you assess the clinical stage here?
So clinical stage, as the median sulcus is obliterated, it definitely involved both lobes, sir. So it will minimum of T2C, sir.
Very good. One. Second thing?
Second thing, we'll assess for lateral sulcus, sir. If it is, if there is extraprostatic extension assessment, we will do lateral sulcus, sir.
I'm sure all of you, I'm repeating that point which Rajan made now. If we are able to feel the median sulcus properly, that means the disease is either limited to one side or it is present on both sides and not crossing the midline. That is what it is. Now, Rajan mentioned that this patient has got a hard, irregular prostate. That means the entire prostate surface is irregular and hard. That means the disease is involving both the lobes. And on top of that, he also mentioned that the median sulcus is obliterated. That means the disease is actually involving more than one lobe. That is what it means. More than one lobe means it is involving both the lobes, means it is a stage 2C. Okay. So it should be the 2C or it can be 3A, 3B or 3, whatever. Now the second thing is seminal vesicle. He did not mention that it is palpable. That means a seminal vesicle is probably not infiltrated. That means it is not a T3B. Okay. So it may be 2C, T2C, or it may be a T3A pair. What is T3A?
Extraprostatic extension, sir, but not fixed to adjacent structure.
Yes. So it may be either T2C or it may be a T3A. Clinical staging. So clinically, you can, for all practical purposes, you can keep it as T2C. T2C, if you see, which risk stratification will that come under?
Intermediate risk, sir.
It comes under intermediate risk. Okay. But if you look at the serum PSA, it is very high, more than 20. So automatically it becomes a high risk category. Okay. When you talk about intermediate and high risk, the question of 4+4, 5+4 doesn't matter at all. either 4 plus 4 or 5 plus 4 or 4 plus 5 or 5 plus 5, it hardly matters because PSA is 3000 here. And the core positivity, percentage of core positivity, none of this really matter here because it automatically gets upgraded to high grade or a very high grade type of CA prostate here. Okay. So that is what you should remember. Whenever you are given a case of CA prostate, the first thing you should do is risk stratification based on the clinical assessment and the biochemical interpretation. And once you get the biopsy report, you should be able to do a risk stratification. This patient falls under a high risk to very high risk category. Okay, fine. What next you want to do further?
So as it falls under high risk, I would like to do a evaluation, sir. I would like to
Is
do
it possible, Surya, to run through that D-amico risk stratification table?
Yes, sir.
For the benefit of those who had not attended last session.
Dr. Rajan,
Sir.
you told trust there is a prostate, it looks different and there is a different mass palpable.
Yes, sir.
What you are palpating, the digital rectal exam, what is that the prostate or is that node mass, pelvic node mass?
Sir, actually we couldn't separately palpate, sir, because when we are doing DRE, there was a huge irregular mass, sir. We couldn't appreciate whether it is prostate or pelvic mass, sir.
Okay.
So after the trust only, we could get to know that it was a separate mass from prostate, sir. Well, clinical examination, we thought it as prostate only, sir. Large irregular prostate.
But the way you described the mass, what Dr. Vail is asking is a very, very important question here. See, you thought it was a prostatic mass.
Yes, sir.
The ultrasound abdomen confirmed that, but the transrectal ultrasound denied that, isn't it?
Yes, sir.
Do you still want to stick on to the clinical assessment that you made correctly, or would you like to call that as a totally different lymph nodal mass or something else, and not the prostate? Very important to make that distinction. Yes. When you say median sulcus is involved, yes, obliterated, that means you're talking about the prostate.
Yes, sir.
Be very, very clear in that.
Yes, sir.
Okay. Be very, very clear. But at the same time, what Dr. Vail mentioned, no, because there is a disparity between what findings you had in a transrectal ultrasound, what you saw in here. You have still not done a CT here.
Yes, sir.
In the ultrasound abdomen that you showed, no, that showed a big mass in the midline, actually. It was the midline, and the bladder was not seen in that section at all.
Yes, sir.
Remember, so for all practical purposes, the mass that you showed in abdomen looked to me like a prostatic malignancy only. Yes. Unless you mention that it is not a prostate, it is arising somewhere else from, it's very difficult for me to believe that. Okay, so that distinction you should be able to make. Yeah, well, go ahead.
I think they wanted to confirm that because, but the biopsy shows it's a prostatic adenocarcinoma. Then that swelling could have been from the prostate only, I suppose.
Yes. Very important that the next axial imaging we may have to do, which will clear all these doubts. Okay. Next axial imaging when you do, it will clear all your doubts. See, whenever you get a case of CA prostate, first thing you do a DRE and make a clinical assessment of whether it is a T2A, T2B, or T2C, or whatever. You cannot differentiate between T2A and T2B correctly, but at least T2B and T2C you can distinguish. Okay, so that distinction you will make. Then with your, that is the first parameter, T staging, and the second parameter is PSA. The third one is Gleason's grade. The fourth one is the percentage of core positivity. How many cores are positive? Okay. The Gleason's grade, serum PSA, T stage. These are the four parameters based on which you will do a D-amico risk stratification, which is the widely accepted risk stratification these days. These are the four parameters based on which you will risk stratify. Because the moment you tell the patient that you have got malignancy, the next thing that the patient will ask is, what stage am I in, doctor? For that, you should be able to stratify, you know. That is the most important thing. So when you look at these four particular parameters, T stage, PSA, Gleason's grade, and the percentage of core positivity, you can realize, you can see that you classify them as low risk, intermediate, and high risk. And each one of these are further classified low risk into very low risk and low risk, intermediate into favorable, unfavorable, high risk into high risk and very high risk. Okay, this risk stratification is very important because based on this only you will plan the entire treatment accordingly. Okay, the next will be planning the treatment. It will only be based on this risk stratification. Then you can go through individually each of these, but this parameter, this tabular column, everyone should remember by heart. Even in the middle of the night, if I wake you up and ask you, should be able to say the risk of stratification clearly without any ambiguity. Please remember, the very low risk and low risk are the candidates who can be considered for active surveillance. They are not the candidates for active surveillance. If at all you want to consider active surveillance, you can consider that for only these two groups. The intermediate favorable, intermediate unfavorable will not be the candidates for active surveillance because they will not be the candidates for active surveillance because the PSA level will be more. When we talk about the criteria for active surveillance, we will discuss that in further detail. Please remember, active surveillance, if you want to put the patient on, it should be a very low risk or a low risk category. For intermediate, low risk, very low risk, intermediate risk, favorable, unfavorable, radical prostatectomy will be the ideal treatment of choice. We will come to that little later. Finally, when I consolidate, I will tell you all that. Please remember this tabular column. Go back to your Rajan. You can go back to your presentation. So this biopsy report is 4+4. Okay, what next you want to do?
So as it falls under high risk category, we proceed with PSMA PET CT, sir.
You'll do a PSMA PET CT. Why not MP-MRI here?
Sir,
what is the role of MP-MRI?
So sorry to disturb, sir. Someone has asked the same question in the chat box also, sir. If
Yeah,
PSA
please.
is 3000, can we do MP-MRI for this patient before doing biopsy is what the question is, sir.
Okay. See, that is a general question that everybody will have. There are many centers which started doing MP-MRI and they believe in the MP-MRI. But generally, for your exam point of view, what you should remember is that a patient in whom you are planning to do a radical prostatectomy, if you think that there is a candidate for radical prostatectomy, probably you can. VP, please put your mute on. Okay. See, a patient in whom you are planning to do a radical prostatectomy will have a role for MP-MRI. A patient with the PSA of 3000, will you do a radical prostatectomy here in this particular individual with a curative intent? If at all a malignancy is confirmed, yes or no, Rajan? Surya?
No,
Sir, before that, I have to do staging.
staging
Sir.
on the patient, sir.
No. I'm asking. A patient with a serum PSA of 3000.
No, sir. It's
What is the question of staging here? It automatically falls in that high risk category.
We won't do, sir.
We will not think of a radical prostatectomy here. Because any patient with a PSA of more than 20, there is a 50% probability that there will be an underlying bony metastasis.
Yes.
A person with a PSA of more than 50, there is about 70-75% chance that there will be a bony metastasis. So this data you should have in mind. Bony metastasis which has already taken place. Is there a role for radical prostatectomy with a curative intent? You can do a prostatectomy, that's a different issue.
Yes.
But is that prostatectomy going to offer the patient a curative intent? The answer is a big no to that. Okay.
Yes, sir.
So first of all, you should remember MP-MRI you will do when you are contemplating on the possibility of a radical prostatectomy with a curative intent. Because if you do a biopsy transrectally, what happens is the edema, the inflammation, the induration, the fibrosis at the site of biopsy taken, the hematoma, all this will actually, if at all you want to do an MP-MRI later on, that will mask all the findings. That will alter all the findings. So, an MP-MRI should be done in a virgin prostate. A prostate which has already been needle pricked 12 times, you normally will not do a sextant biopsy. Plus biopsy, you will do at least a 12-core biopsy, plus additional 13th, 14th core targeted biopsies. So that is the way you do trust biopsy. You in the exam, you will never mention sextant biopsy. Say, because sextant biopsy, if you do, there is a possibility that the second biopsy, if you do, you will get 30% of the cases which are missed out in the first instance.
Yes,
they will get picked up. So there is a very high false negativity with your sextant biopsy. So nobody advocates a 6-core biopsy. If at all you want to do a transrectal biopsy, you will do a 12-core biopsy. Plus, in addition to 12 cores, 13th, 14th, or 15th core, which will be targeted at the nodules, whichever you find in the transrectal. So that will be the biopsy. So if you prick the prostate about 10 to 15 times, just imagine how it will be. There will be so much of hematoma, there will be so much of inflammation, so much of edema, so much of fibrosis around the prostate gland that if you do an MP-MRI later, the findings will be altered. Okay, that is number one. Number two, that's the reason why When we do a radical prostatectomy, again, we don't do it immediately. We wait for all this inflammation edema to subside. Minimum 2 to 4 weeks, we will, not 2 weeks, 3 to 4 weeks at least, we will wait. Wait for a month, and then, because otherwise the plane will not be delineated. You will not be, when we talk about the prostatectomy, we talk about various intrafacial, interfacial, and extrafacial prostatectomy. So that facial discrimination will not be possible if you do it and there's so much of inflammation around, so much of edema around, fibrosis around. So you always will wait. So by and large, for your exam, from your exam point of view, now answering your question, if you have such a patient in whom you feel radical prostatectomy is not the definitive treatment, in whom you are going to do a PSMA PET to make a diagnosis of a metastatic CA here, MTMRI has got no real role to play, no great role to play, no valid role to play. In which case, you need a tissue confirmation. You can either do a transrectal ultrasound guided biopsy or even a finger guided biopsy. That should be sufficient because this patient has got involvement of both the lobes here. All that you will probably need is only tissue confirmation, because number of course positivity is immaterial because the patient has got a 3000 plus the PSA going into the high risk or very high risk category. The number of cores or percentage of each core positivity, all that becomes immaterial here as far as risk stratification is concerned. So either you can do a transrectal ultrasound guided biopsy or you can do a finger guided biopsy and get a tissue confirmation, take it from there.
Yes, sir.
You understand?
Yes.
Whereas if you have a patient, same patient with a PSA of 8, even if he is 69 years, the earlier concept was that when I was a postgraduate, if the patient is crossed about 60, 65 years, radical prostatectomy is contraindicated. But even these days, 80, 85-year-old male is still very active. So if you feel that the patient is going to live longer, about 7 to 10 years at least, then radical prostatectomy, even at the age of 80, 85, is still indicated these days. So age is not the criteria here. The only criteria here is the PSA level and the risk of stratification. Okay, so that is what you should aim at.
Yes.
Has this answered your query? Say yes or no. The chat box. Go ahead, Rajan.
Yes. So PSMA PET was done, sir. There was a PSMA AVID.
Why don't you do FDG PET? Why do you want to do PSMA PET here? FDG PET is so easily available all over the place.
So for
PSMA
CA,
PET,
so CA prostate in FDG PET is not indicated because it is a slow growing tumor, sir. So rate of glycolysis will be less. So FTG uptake will be less, sir. Also, FTG will be excreted through genitourinary system, sir. So when the contrast get stagnant in bladder, then we can't able to assess the lesion properly, sir.
good, very good. These are two reasons why FDG PET is not indicated here. Why PSMA PET then?
So because prostatic tissue has an AVID for PSMA, sir. So even the metastatic tissue will have the PSMA avidity, sir.
No. What? Can you repeat it? Say it again.
The metastatic prostatic tissue have avidity for PSMA, sir.
Metastatic prostate will have affinity for PSMA means what?
So uptake will be there, sir, even with the metastatic tissue, the prostatic.
No. Is this PSMA is present in the bone or in the prostate or in the metastatic site? See, there will be an overexpression of prostate-specific membrane antigen by the prostate malignancy. Okay.
Yes, sir.
So in prostate malignancy, there will be overexpression of prostate-specific membrane antigen. So if it is deposited in the bones, if the prostatic cancer cells are deposited in the bones, there will be overexpression of PSMA at those sites. You understand?
Yes, sir.
Irrespective of the rate of glycolysis, there will be overexpression of PSMA. So this overexpressed PSMA present in the vertebral bodies or in the lymph nodes or elsewhere will get easily picked up in the PSMA PET sheet.
Yes.
So that is what the reason is. Okay, fine. Go ahead.
When PSMA
What do you
PET,
see here?
there was a increased PSMA avidity in prostate, and also there was a bulky PSMA avid lesion in the left pelvic region, sir, closely abutting the bladder.
Yes.
And this was the report, sir. Prostatomegaly measuring 29 cc with increased PSMA uptake, sir. And bilateral seminal vesicle invasion is also noted in PSMA PET. And also there was 2 PSMA with large lymph node mass measuring 7.8 into 6.4 centimeter and 5.2 into 4.1 centimeter in left external and common iliac region. Another PSMA with lymph node measuring 0.7 into 0.6 centimeter in left common iliac region, and PSMA with lymph node measuring 1 into 8 centimeter in right external iliac region, sir.
So both sides, iliac groups of lymph nodes are involved.
Yes, sir.
External iliac, internal iliac, common iliac, all the nodes are involved here, isn't it?
Yes, sir. And also
What are the first lymph nodes that you expect to get involved in CA prostate?
so obturator nodes, sir.
Which is part of your
The external iliac nodes, medial group
of external iliac group of lymph. Fine. So external iliac group of lymph nodes are bulky here, 7 to 8 centimeters in bulk. Also, you get a 2 centimeter node on the right side as well. Okay. Bilateral iliac lymphadenopathy.
Yes, sir.
Okay. Okay. So what do you want to do for this individual? Any bony metastasis? Yeah.
No bony metastasis, sir. No liver, no lung, no bone metastasis. Only bulky lymph node metastasis. So clinical staging will be T3B and N1, sir. So it is a locally advanced disease, sir.
No, it is not a clinical staging. Clinical staging is what?
Sorry, after imaging.
Radiological staging. Radiological staging. Radiological staging will be, though clinical staging was a T2C, now the radiologically you are upgrading the stage to T3B.
Yes, sir.
T3B, is it?
Yes, sir.
T3B and
N1.
N status?
N1.
N1. What is N1?
Metastasis to the regional lymph node, sir.
Irrespective of the size?
Irrespective of size. Metastasis to regional lymph node will be N1, sir. If it is non-regional, then it will be M1A.
Okay. I'm not very sure.
Okay.
Can you please tell us about SUV, sir? Shashank has raised a question. Okay. See, the SU value is one value which is very important for you to make a diagnosis of malignancy. The higher the SU value, the higher the probability that there being a malignancy. So that is what we normally will do in your FDG PET, where you have a lymph node which is detected with a high SU value of 4.5 or 5 and above, you call it a malignant node. Okay, so that is the role of SU value. The problem here with your CA prostate, not only CA prostate, for all urothelial malignancies or for even a renal cell carcinoma for that matter, the SU value will not be very representative here. The SU value is something which you take into consideration based on the region of interest that you focus upon. If you are looking at the renal mass, if you are looking at one RCC for that matter, you have so much of pulling up of the tracer activity in the kidney, in the galactic system, and you have a mass sitting over that, the SU value will get altered that. You will get a pseudo high value. And that will not be a representative of the actual SU value of the particular tissue that you are dealing with, that you're concerned about. So SU value is useful in patients in whom there is no tracer activity accumulation happening. Like for example, in patients with the testicular tumor for that matter. In patients with prostate malignancy or renal malignancy also, not for making a diagnosis of malignancy, but for the lymph nodes. Here in this particular case, we don't need a diagnosis of CA prostate to be made in your PET CT because you have already had a tissue diagnosis done. All that you need is only to see if it has gone beyond the prostate, either into the lymph nodes or into the bony metastasis. In which case, even if you do an FDG PET, that will be representative here. The SU value will be high here because the SU value is indicative of malignancy, and these malignant deposits in the nodes will definitely have a higher SU value. So in such instances, PSMA PET is really not required, just adequate if you do an FDG PET itself. Okay.
So now the stage will be T3B N1, sir. It's a locally advanced.
Okay, locally advanced. So what do you want to do for this individual?
Combination therapy, sir.
I don't know what that combination is.
So the main modality will be androgen deprivation therapy along with for this patient radiotherapy.
See, you have to address the prostate.
Yes, sir.
You have to address the lymph nodes here.
Yes,
These are the two priorities for you.
Yes, sir.
Isn't it?
Yes, sir.
So what do you want to do? These are very controversy. When do MPMRA first? Somebody has raised that question now. What is that? The same question propping up again. Okay, MPMRI and trust we will discuss finally in the end. I think somebody is raising the question again. When we talk about the promise study, when we talk about precision trial, I will cover that again in greater detail. Okay, that will
Sir,
give you more
they have
clarity.
asked again about the controversy between doing MPMRI and prostate biopsy.
That's what I was telling. Okay,
Yes.
fine. I will discuss that when we have a final summary being discussed. So that time I
Sir,
will.
we'll have one more screenshot, sir. We have reached the maximum participants, 100, sir.
Wonderful. 98 now.
Yes, sir.